California. Mr. Obernolte for his 5 minutes of questioning.
Thank you, Mr. Chairman. Thank you to our witnesses. I find this a really not only interesting but critically important topic. This technology has the potential to accomplish these seemingly contradictory goals of, at the same time, improving patient outcomes, but also reducing healthcare expenditures, and I find that incredibly exciting. Mr. Ezell, I wanted to start with you. We've been having this discussion about false positives and false negatives. And I think Chairman Griffith asked you about the false negatives, and you had a kind of a fulsome discussion about that. Dr. Zuckerman brought up some research that has been talking about false positives and false negatives, and particularly the Annals of Internal Medicine had an article recently where it said that it's unclear whether these tests detect cancer at a later untreatable stage or whether they detect very early stage precancerous lesions that might have never developed into cancer. So I find this concerning from the standpoint of false positive. From a patient standpoint, if I'm a patient, I would rather have you tell me I might have cancer, and then so I can do some more research even if I don't. But how do we parse this middle case where we're detecting cancer that is actually there, but it's a precancerous lesion that actually in real life, if we'd done nothing about it, would never develop into cancer? So, I mean, how should we be thinking about that kind of outcome?
I guess the first point I would make is that these MCED tests are being intentionally designed to try to ferret out the most aggressive cancers that are the fastest growing and not the indolent cancers. I'd also note, as Columbia University professor of oncology, Azar Razi says, the $27 billion America spent on cancer screening in 2020 yielded about 9 million positive results annually. Of those, only 204,000 turned out to be actual cancers, with 8.8 million being false positives. So this is a challenge we currently confront of false positives in the current screening paradigm. And I believe that given a very low comparative false positive rate, MCED tests are going to be significantly higher than single cancer screening over time in terms of their positive predictive value.
So, I mean, would you, in this particular case, where you've got a precancerous lesion that could develop into cancer at a later stage, and you detect that, is that a false positive?
I'm not a scientist. I'm not a doctor.
Me neither.
So I'm not going to speak for a medical professional who would characterize that state of a potential disease. I'm here today to kind of address the policy environment I think Congress can put forward to support the evolution of these technologies going forward.
Okay, thank you. Dr. Brinton, I'll bring that same discussion to you. As we think about national coverage determination, how should we be thinking about this issue of false positives and false negatives? Because I mean, on its surface, if we've got technology that can simultaneously improve patient outcomes and decrease healthcare expenses, that should be a no-brainer, except for this issue. Like, how do we factor that in to the decision-making process?
I think we come back to one of the things I mentioned previously, which is obviously it's beneficial for patients to actually potentially, obviously better outcomes, reduces dollars, but ultimately this is a decision to be made for access to be available for a physician and a patient to make a decision, to manage a false positive or a false negative for that matter. So it's a decision. So we're providing access to the technology so that the latest technologies that we have been proven to be safe and effective are available to the Medicare population, that they can make that decision with their physician.
Mm-hmm. Okay. I think being patient-centered probably makes sense. And then in a little bit of time I have left, I wanted to ask you about the application of artificial intelligence to this process, because one of the things that I've been surprised by is that most of the low-hanging fruit in terms of the efficiencies that AI can wring from the process and as regards healthcare is with administration. But I can't help but think, looking at this, this bureaucratic process of coverage determination and wondering if CMS might be able to use AI to make themselves more efficient. What do you think about that?
Well, I appreciate the question, and AI is obviously creating incredible capabilities. I'm an interventional cardiologist, and probably not the right person to answer a question about AI.
All right. Well, I want to thank everyone for your engagement on this issue as we work through this, and really exciting technology, really exciting times for not just technologists, but also patients in the United States. I yield back.
If I could add, just briefly.
You got 16 seconds, but go
I
ahead.
think artificial intelligence can transform government operations, and every single agency of the U.S. government should have a strategy for how it can deploy artificial intelligence to accelerate and improve delivery of constituent services.
Yeah, well, I would hope everyone would be in furious agreement with you on that. Thank you. I yield back, Mr. Chairman.
Gentleman yields back.